So good afternoon, everybody. I'm Megan Vo. I'm one of the faculty members. I'm a clinical associate professor in the Division of Adolescent Medicine here at Stanford. And joining me also is Nandini Datta. She's one of our fabulous psychologists in the Division of Child and Adolescent Psychiatry and one of my um, very valued colleagues in the eating disorder program. And we're asked to speak today about eating disorders in adolescents, and it's a huge topic, and I know one that is touching many of us in clinical practice, for the last couple of years, if not before. And so we're going to focus on recognition and diagnosis, and I will touch a little bit on kind of outpatient management, when to refer, etc., recognizing that there's no way we could cover it all, no matter how much time we're given. So we have no financial relationships to disclose. And learning objectives today, we're hoping that we will be able to recognize the signs and symptoms of eating disorders, describe diagnostic categories of eating disorders, describe the medical workup and outpatient management, and recognize when to refer. And, my caveat of that is if ever in doubt, please refer. We're always happy to see somebody who doesn't have an eating disorder in clinic. Though it's pretty rare. So if ever in doubt, please call us or please refer. We're never upset about getting those referrals. I like to frame these types of things in terms of a case. So this is somebody that I took care of when I was in training, actually. So I was able to follow this case from the beginning to the end. SH is a 12-year-old Asian American female who presents for her annual well child check. She's overall been well, however, her mom reports that for the past 6 months, she's been refusing to eat foods that mom prepares at home, such as rice, which is very disturbing to mom. And she only likes American food. She's also increasingly interested in watching Korean dramas online, has been making comments that she'd like to look like a K-pop star, and mom thinks she's lost about 25 pounds and has not had a menstrual period in several months. So key questions when you're seeing this type of patient in clinic, what is the diagnosis? What workup would you do? What workup should you do? And then what referrals would this family benefit from? And hopefully we'll get to some of these things. So just to back up, to frame it, nutrition and adolescence. I mean, the big takeaway is this is the period of time of, the second greatest growth, other than that first year after birth between 0 and 1 year of age. Adolescence is when they're forming all of the tissues they're supposed to form that are going to last them for the rest of their lives. And this is what I tell patients. So their needs are very high. They gain 20% of their adult height, but 50% of their skeletal mass because of the increase in bone density during this time period. As such, their BMI increases because also muscle mass increases, and their overall calorie and protein requirements are the highest that they have been, again, other than that first year of life. But poor eating habits are so common. I mean, I think one of the things that I tell the residents often is just get, if you're in doubt, get a 24-hour diet recall, because it gives you a sense of are they skipping meals? Are there entire food groups that they're not eating? Because, show me a kid that eats breakfast and or lunch. It's really common to be able to skip those things because they're busy or they're socializing or whatnot. For a generally inactive, just regularly growing youth, a male adolescent may need up to 3,000 calories a day just to grow. And a female may need almost that much, 2,200 to 2,800 calories per day. And we'll talk about it. But if they're athletes or they do any kind of activity, they need even more to be able to repair their tissues and prevent injury. Everybody is obsessed with protein. And how do I get the most protein and what type of protein powder is the best? But it turns out that for adolescents, they actually need a lot of carbs. So this is just intake for growth. About 50% of their daily intake should be carbohydrates, 30% healthy fats, and only 20% really needs to be protein. And many of those protein sources can be plant-based. It doesn't have to be, getting 5 double doubles. We generally define athletes as those who do about 2 hours of activity per day. I mean, and that's inclusive of everything, walking to school, PE, etc. So these kids may need, an additional 1,000 to 1,700 calories a day to make up for what they're expending through energy, through activity. And when we think about what a young athlete needs in the aftermath of a workout, actually they need even more carbohydrates because glycogen is what the muscles are going to go after first for fast energy. Then they'll burn fat, and only after all of those reserves are exhausted, then they'll go after the protein sources. So there have been some really cool studies on athletes about like what types of post-workout fuel have the best repair and actually have the best muscle performance the following time they exercise. And something like a 2% chocolate milk is like the perfect post-workout snack because it has carbs, fat, and protein. When you're seeing these folks in your clinic or on the ward, and maybe like eating disorder isn't like the first thing that comes to mind, but they're drifting, there's some red flags, what things do you look at? And I always look at the weight, the height, the BMI, and then their trajectory. So are they crossing percentiles? Has their height stagnated? Have they lost weight? Because it's really not normal for an adolescent who should be growing to lose weight. And so some additional historical questions like, do you have any concerns about your body weight, shape, or size? Have you ever tried to make any changes to your weight or shape? Have you ever tried cutting out foods you previously ate or dieted or skipped meals or fasted? I try to leave these questions open-ended because dieting and fasting can mean different things to different people. So having them kind of describe to you what they normally do. And then depending on concerns, have you ever vomited to try to lose weight? Sometimes I'll say like, does the food come up? So it's little bit kind of more neutral. Has your weight changed in the last year? And then, like I said, the 24-hour diet recall. Red flags, crossing percentiles, the kid who you've kind of given them a talking to, I need you to do better, I need you to do breakfast, and you see them again and they're not gaining weight, those are other red flags. New restrictive diet, so like our patient from the initial case, especially if it's different from what the family normally eats. Because sometimes eating disorders will hide in socially acceptable ways to restrict. New vegetarianism, new gluten-free, Whole30, keto, etc. Those are the kinds of things you may want to probe and take a closer look at. Changes in eating behavior, so eating in secret, skipping meals, lunch food coming back, that kind of thing. And of course, missed menses. Sometimes people don't know, so also asking about like, hey, when was the last time you had to buy products? Or asking them to track it so that they have a better sense of what's happening. These can be very important historical clues. Dr. Dada will talk more about, how we make this diagnosis, but in a primary care setting, this is one of the screeners that I think is easiest to use because it's short. So this is called the SCOFF, and it's from the UK, so that's why the language is such. Do you ever make yourself sick because you feel uncomfortably full? So vomiting. Do you ever worry you've lost control over how much you eat? Have you recently lost more than 1 stone in a 3-month period? 13, 14 pounds. Do you believe yourself to be fat when others say you're too thin, or would you say that food dominates your life? And a score of two or more. It doesn't give you the diagnosis, right? But it's a positive screen and warrants further evaluation. And I've seen this implemented in clinics in like the pre-visit questionnaire, for example. It's pretty easy to do. And then thinking about the scope of the problem. So these are prevalence estimates, mostly community samples, but basically like up to 10% of adolescents will meet criteria for an eating disorder. And some community samples show that even more, like up to 30% of people at any given time are walking around with some kind of sub-threshold eating disorder behavior or body image dissatisfaction. It's a huge problem. And we can, we'll talk about why that is, but it's, not rare, and eating disorders have the highest mortality rate of any mental health disorder. So it is, warrants our attention. It is important. Some risk factors, these are multifactorial illnesses, but there is something unique to the adolescent age and the developing brain. There's some interesting studies about perhaps it has something to do with the role of leptin on the developing brain, because it's pretty rare to have an adult person just all of a sudden develop an eating disorder who never had one to begin, when they were younger. So something about adolescence. We certainly know that these run in families, monozygotic twin studies. There's people who are doing gene mapping, who've identified loci that are associated with eating disorders. there certainly are cultural influences, social media being one of them. We know that there's a higher incidence in westernized countries. And that it seems to affect girls more than boys, although I think in the coming years we'll see these prevalence numbers changing somewhat because of the increased inclusivity of the criteria. They really used to be, and I would argue maybe still are, very gendered. And boys may express body image dissatisfaction in different ways than girls, and thus maybe not get like kind of a full threshold anorexia diagnosis, for example. Um, and I'm going to actually stop sharing and I'm going to hand this over to Dr. Dada to talk about diagnosis.
Thanks so much, Dr. Vo. So I'm going to go ahead and share screen so we can start talking a little bit more about diagnostic factors. Bear with me as I adjust this. Okay. That should be, you should be seeing my slides now. So we're going to talk a little bit more in depth about the key diagnostic features of eating disorders, going through all of the different eating disorders, kind of the DSM-5 broad categories, how we make these diagnoses, and what we see clinically as well. I think Dr. Vo did a great job giving an introduction for some of this. So let's dive right in. We're going to start with anorexia nervosa, which I'm sure you've all heard of. Anorexia nervosa is an eating disorder where there's a restriction of energy intake relative to requirements, leading to significantly low body weight. This is a mouthful. This means dietary restriction, skipping meals, cutting out food groups like Dr. Vo mentioned, where it results in significantly low body weight in the context of somebody's age, sex, developmental trajectory, impacts their physical health in bad ways, loss of menses, things like that. What is significantly low body weight? Because that sounds a little bit vague. Less than what's minimally normal for somebody of their age, sex, and developmental trajectory. All of these behaviors are kind of driven by this fear of shape and weight concerns. So not wanting to become fat, being afraid that they're going to gain weight, coupled with a disturbance in body image. So people with anorexia nervosa, even at a significantly low weight, may look in the mirror and say, I could be thinner. I don't think I look thin. If we ask these kids in outpatient clinics, you know, what would be your ideal body weight? Often we hear no number would be low enough, or they give a number, and if you ask, okay, so you're at this number, what do you think? No, it's actually not low enough. So you see this disturbance in body image kind of pervasively. The average age of onset for anorexia, as is true for most of the eating disorders and feeding disorders I'll be going over, is adolescents, around 18 years old, with a lifetime prevalence of 0.6%. More prevalent in females over males with a 10-to-1 ratio. This is going to be true again of most of the eating disorders we'll be going over, with the exception of one, which I'll get to. Crude mortality rate of 10% per decade. Anorexia nervosa has two different subtypes. So we see a restricting subtype and a binge eating and purging subtype. Binge eating and purging subtype, you might be saying, well, isn't that just bulimia? Anorexia nervosa binge eating purging subtype is different from bulimia because of the low weight stipulation that's needed to make an anorexia diagnosis. In addition, the binge eating episodes are actually can look a little bit different in this subtype as well, where in bulimia, the binge eating is typically objective binge eating episodes, so eating an objectively large amount of food in a discrete period of time, which is 2 hours or less. A subjective binge eating episode is eating what would be constituted as a normal or small amount of food, but still having that associated loss of control. Restricting subtype is what we sort of just talked about. So dieting, fasting, restricting intake, cutting out food groups, skipping meals, things like that, and or exercise. Crossover between these subtypes is not uncommon, but you make the diagnosis based on the symptoms that are being presented in that moment. So sometimes people have restricting subtype anorexia, and then they will later go on to develop the binge eating purging subtype, but you would diagnose whatever they're presenting with right then and there. The DSM-5 added some specifiers for severity, which I have in the bottom left-hand corner. So For anorexia, it's based on weight status. This changes based on what diagnosis we're talking about, but we'll go over them as we get to the other ones. All right, moving to bulimia nervosa. So bulimia nervosa is described as having binge episodes and compensatory behaviors. So binge episodes are eating in a discrete period of time and having an associated loss of control. When I'm describing this to patients in the clinic, I say something like, especially if they're younger, because sometimes loss of control is kind of a hard concept to grasp, like feeling like you're a ball rolling down a hill, gaining speed, or feeling like you're kind of out of control. Do you ever feel that way when you're eating? Do you ever feel like once you've started eating, you can't stop? And generally, if someone's experienced a true loss of control while eating, they'll know exactly what you're talking about. And they'll be like, oh, yep, I've experienced that. So that's a pretty good probe for loss of control. Bulimia is also characterized by recurrent inappropriate compensatory behaviors that can be self-induced vomiting, misuse of medications, diuretics, laxatives, things like that, excessive compensatory exercise. So not just like, going on a walk, but exercising because you feel like you have to. There's that kind of that compulsive nature that you have to probe for. And similar to anorexia nervosa, there is self-evaluation unduly influenced by body shape and weight. Here we see, again, adolescent, age of onset, lifetime prevalence of 1 to 1.5%, more seen in females over males, and accrued mortality rate of 2% per decade. Couple other things about bulimia. Onset is before puberty. So after being diagnosed, and I think Dr. Vo touched on this, being diagnosed as an adult, if you've never had this in adolescence, is pretty rare. There are some risk factors to developing bulimia, or having a binge episode. If you've been restricting the whole day, you're more likely to have a binge episode later in the day and then start that binge purge cycle. Starting a new diet, so some intermittent fasting, things like that, like big changes to eating behaviors can be risk factors for having a binge episode, stressful life events. Unlike anorexia nervosa, where DSM-5 severity was calculated by weight status, here it's calculated by how many compensatory behaviors are being endorsed in a week. So for BN, you have to have at least one binge episode for the past 3 months. Severity, you look at the compensatory behaviors rather than the binge episodes. So how frequently someone is purging or having laxatives or diet pills, those kinds of things will mark a mild, moderate, severe, or extreme level of diagnosis. Moving on to binge eating disorder. So binge eating disorder, you can see average age of onset is a little bit older than we see in anorexia nervosa and bulimia. Lifetime prevalence is a little bit higher, and again, seen more prevalently in females over males. So a big difference between binge eating disorder and bulimia is there's no compensatory behaviors here. We just see binge eating, and binge eating and binge eating disorder is associated with at least 3 of the following. So eating much more quickly, eating until it feels like you're painfully stuffed, eating large amounts of food, even when you're not physically hungry. So not being able to distinguish those interoceptive cues of feeling hungry in your tummy versus hungry in your head, eating alone because you feel embarrassed by how much you've been eating, feeling really disgusted, depressed, guilty after a binge episode. And just a couple of other things about binge eating disorder. People with binge eating disorder have a lot of distress and shame around their binge eating. Treatment outcomes are actually better compared to bulimia nervosa, and there's no compensatory behaviors. To go back to that second point, though, I want to touch on the fact that for anorexia nervosa and bulimia nervosa, we consider these, especially anorexia, to be egosyntonic. And what I mean by that is they actually feel good for the person that has this disorder. And so a lot of the behaviors like hiding food at dinner or sneaking around and trying to find an opportunity to purge, these are things that make the person with the disorder feel better. And so what they're doing is working to protect and maintain the eating disorder. This is different than somebody with binge eating disorder or depression, where the symptoms actually feel really bad and shameful and not good. And you might be more motivated in binge eating disorder to go to treatment and get better. People with anorexia and bulimia, an additional challenge in treatment is that they're not necessarily 100% on board with getting better. They actually want to do things in service of maintaining the illness. I also like to tell families and kids at the outset of treatment and diagnosis that we know that you didn't wake up one day and think, I want to have anorexia. That sounds like a great way to spend the next couple months of my life. We know that rather it's something like starting a diet, like Dr. Bo was mentioning, going vegetarian, something that really starts with maybe innocent intentions and spirals out of control. And then suddenly you're realizing that you're engaging in all these other behaviors, your weight has dropped. And I like to point this out to parents and adolescents, to reduce some of the guilt that they might feel around this diagnosis. And was it my fault? Was it something I did or didn't catch? I feel like it's helpful to point out that this is an illness, and not a volitional choice. Severity for binge eating disorder, so flip back to the slide, is marked in the upper right hand corner, where it's by number of binge episodes in a week. So mild, moderate, severe, and extreme. Now we move on to avoidant restrictive food intake disorder, which is my favorite eating or feeding disorder. It's kind of a strange thing to say, but I like it because it's relatively new and we're doing a lot of research to understand this disorder a little bit better. ARFID is characterized by eating difficulties that result in persistent failures to meet appropriate nutritional or growth needs, and is also characterized by having one of the following. So either significant weight loss, nutritional deficiency, so in extreme cases, seeing things like scurvy or anemia, needing to take iron supplements, dependence on tube feeding or nutritional supplements like Boost, so having a G tube, having boluses, or most of the calories come via tube feeding, and marked interference with psychosocial functioning. So these are kids that, might have difficulties going to a birthday party or a sleepover because they don't like pizza or they don't want to eat cake, or they really have a lot of sensory sensitivity to what other people around them are eating and those kinds of smells. A big difference that makes this not the same as anorexia nervosa is that there's no shape and weight concerns in ARFID, and rather the restrictive eating is driven by three different things that we'll get to in the next slide. But before we flip there, I just wanted to point out that for ARFID, the average age of onset is younger, so less than 12 years. And we don't know the lifetime prevalence because this diagnosis is relatively new to the DSM-5. It was added in 2013, which seems like actually quite a long time ago, but in the realm of research world, it's still fairly new, and lots of treatments and studies are underway to learn more about what works best for ARFID. And this is the one diagnosis where we see it more prevalent in males and females. So to go on to what drives the eating behaviors or differences in ARFID, not body image concerns, as I mentioned, rather we have these three overlapping subtypes. So to start, we have selective eaters. These are our kids that are very sensory sensitive. These are kids that you get them Cheerios from Trader Joe's instead of Safeway, and they know, and they will not touch it. And it is the biggest insult. Or you have kids with low appetite. Low appetite kids are ones that maybe have historically always kind of tracked low on their growth curve, maybe had difficulty latching or with feeds as an infant. Food is not rewarding to these kids. They don't remember to eat, and they tend to be lower weight. Or there's fear of aversive consequences kiddos, where things were going okay, they were tracking okay, and then something happened, like they got sick after eating something, or they choked on something, and suddenly a bunch of foods drop off of their daily eating repertoire, and their growth curve kind of has an acute, abrupt drop. So these are different sort of reasons that kids with ARFID don't eat the way that other kids their age might be eating. Selective sensory sensitivity kids are often seen comorbid with ASD, but not always. Fear of aversive consequences kids sometimes are seen overlapping with GAD or generalized anxiety disorder. And you can certainly have more than one subtype or all three subtypes. These subtypes are not empirically derived in the literature. They're kind of clinically described in the DSM-5, but not a part of the diagnostic categories. I am working on getting research to change that, so stay tuned. All right. So then we move to other specified feeding or eating disorders. So these are the categories where you're getting clinically significant distress or impairment, but you're not meeting full criteria for any of the aforementioned eating disorders. And there are some specific examples that are described in the DSM-5. So there's atypical anorexia, where you're meeting all of the sort of check boxes for anorexia, except for the low weight. And this can happen if somebody maybe starts out at a higher weight, loses a lot of weight in a short period of time, potentially has medical vital sign instability, as a result, but still is falling within that healthy weight range. But their behaviors and their thoughts and their body dissatisfaction all tracks with anorexia nervosa. BN or BED of low frequency and limited duration. So this is having all the symptoms of bulimia or BED, but at a lower frequency, so less than once a week for the past 3 months. Purging disorder is basically bulimia or anorexia, binge purge subtype, and with the absence of any binging. Night eating syndrome is one where you ask kids, like, do you ever wake up in the middle of the night, get up to eat something, and then just go right back to sleep? And if they say yes, and it's happening at a certain frequency, this is what night eating syndrome is. It can't be better explained by external influences, and it has to cause the person distress. And lastly, we have the category of unspecified feeding or eating disorder. So this is, again, where symptoms are aligned with some of the diagnoses that we talked about earlier, and they're causing clinically significant distress or impairment, but not meeting full criteria. So this can be prescribed when the clinician chooses not to specify a reason or that criteria aren't being met, or in contexts where there isn't sufficient information gathered in order to make a specific diagnosis. For example, in the emergency room, things like that, you can give this diagnosis if you need to get more information to rule out anorexia or ARFID or something. And with that, we are all done and have gone through all the different diagnoses, and I look forward to discussing questions at the end. Thank you.
Thank you. Okay, I will pick up there and we'll move on to the medical complications. And thank you for putting your questions in the chat. They're all really good ones that I took a look through, so we will get to those at the end. So we know we see these patients in the clinic, on the wards, kind of wherever we are. And I think my big takeaway is that these eating disorders can affect every system. And they really provoke, for the most part, a hibernation response from the body. So, like, your body tries to cut corners and save energy by shutting anything that it views as extraneous down. And those extraneous things can be things like heart rate and cognition, because it's just trying to keep going. So, commonly we'll see bradycardia, hypotension, hypothermia. Cognitively, what you may see is changes in memory or attention. The reward pathways get totally messed up, problem solving, decreased cognitive flexibility. And then if we were to image these patients, and these studies have been done, what they see are actual structural changes in the brain. So decreased cortical thickness, increased ventricular size, microstructurally, there's almost really interesting, like, total rewiring of pathways like the hippocampus and the amygdala in frontal processing type tasks. So the malnutrition really affects everything and can explain why you have a conversation with somebody and you're like, oh my gosh, we are like totally looping. Like, I thought we just addressed this and yet we're back here. It's really because the brain cannot hold on to information in the same way that a nourished brain can. And something that I often hear is like, oh, well, they're doing so well in school. It's like, the human body is amazing. It can keep going under really extreme circumstances. And yet you can see, like, sure, they might be getting all A's, but they've withdrawn from their friends. They're not interested in their other activities anymore. They're short with people. Their emotions are all over the place. So to be able to keep going with one thing, it's cutting corners in many others. These admission criteria, so today, the Society for Adolescent Health and Medicine came out with a new position paper, like just this moment before I logged on to here. And so these have changed a little in the last couple of hours, and we'll talk about it. But the big ones are reasons for admission for medical instability would be bradycardia. It is incredibly unusual to have an adolescent be healthy and normal and have a resting pulse less than 50. That's well below the first percentile for just a normal healthy heart. And I would say is a diagnosis of exclusion. Like, if you have all of their heart rates from the time they were 2 and they were always 45, like, great, that may be the way that they're wired. But if you have historical heart rates, or if you don't and you have a brand new person with weight loss, who has a heart rate of 45, you would want to get them better nourished and work that up. And so that's a reason why folks end up getting admitted for monitoring and for nutritional rehabilitation because of the risk of ventricular arrhythmia. Hypotension, so a BP less than 90/45 may warrant admission. Hypothermia, certainly, because, if they're chilling in your ambiently warm office and their temp is less than 35.6, their body is really trying to conserve energy. Orthostasis, so this is the change in the SAM position paper. So orthostasis has been defined as a pulse rise of greater than 20 when you go from lying for 5 minutes to standing for 2. We actually don't use a sitting set of vitals to determine orthostatic heart rate or blood pressure changes. But the new SAM position paper wants us to use a heart rate change of more than 40 for admission for adolescents, because possibly some of this orthostasis can be seen in normal, healthy adolescents. I mean, I think if you try hard enough, you can make just about anybody orthostatic. So for our group, we still will admit for orthostasis, but may not admit everybody, because if somebody's doing great and has the right support, they may not need all the supports of the hospital. But if somebody's doing terribly, this can be a reason to bring them in and to give them nutritional rehabilitation. A systolic blood pressure drop of 20, though, is definitely a reason to consider admission, because if you think about it, right, that's both enotropy, chronotropy, and skeletal peripheral muscle venous return, as well as dysautonomia, all going wrong to equal a blood pressure drop. That's I think certainly warrants thinking about admission if you have somebody who can't hold their BP. Lab abnormalities are reasons for admission. So hypophosphatemia, hypokalemia, hypomagnesemia, hyponatremia are things we can see in malnutrition, and really increase the risk of ventricular arrhythmias, especially when coupled with that bradycardia or EKG abnormalities, for example, prolonged QT. So those would be reasons we may admit somebody. For the Stanford lab, it's just important to know that it won't flag a low FOS until it's in the 2s or less, like less than 2.0. However, we would argue that you could admit somebody for hypophosphatemia of less than 3.0 because of the rapid intracellular shifts associated with refeeding, and your body switching from starvation mode then to storage mode and trying to replete ATP, for which you need 3 phosphates for every molecule. So if you see somebody with a FOS of less than 3.0, even if it isn't flagged, that can be a reason to admit somebody. For potassium, it's less than 3.5. For magnesium, it's less than 1.8. And all of those appropriately flag in the computer system. So refeeding syndrome, this is what we worry about. Thankfully, it's very rare, but it certainly does happen. And what this is rapid shifts in fluids and electrolytes related to an increase in carbohydrate intake. So if people are doing, they're restricting at home and then they do a cheat day, but it's all protein, they probably won't send themselves into refeeding. But somebody who restricts, but then carbo loads, they absolutely could, because your insulin release is in response to that carbohydrate load. And that drives the phosphorus, potassium, magnesium intracellularly, and fluid will follow. And so you can have, over the course of hours, just rapid shifts that then predispose to arrhythmias. A lot of times the symptoms are very vague. So patients will say oh, I feel a little bit tired, maybe a little unsteady. And so that's why we check the labs at least daily. So if you're seeing that, just keeping a close eye and keeping close tabs on what they're eating, because what you would want to do is to stop feeding them until you've got the refeeding under control, and then go gently from there so that you don't worsen the insulin spike. You can see edema in dependent areas, so especially if they're bedbound, not only checking the lower extremities, but checking the tailbone or their back if they're laying on it. They can develop rhabdomyolysis, seizures. Those can be due to fluid shifts and hyponatremia. And like I said, the treatment is to like hold on their feeding and then just supplement the electrolytes aggressively. It's really also important to know, if you, like I, practice in a place where maybe the pharmacy is a satellite pharmacy, that IV phosphorus is not very shelf stable. So if it's a choice between PO phos and IV phos, but somebody has to make the IV phos and bring it over, like just give them the PO phos, because you don't want it to fall any further. And when I start to see on the inpatient side, if I see somebody who doesn't really have symptoms, but they have a phosphorus that's starting to creep down, like it was 3.5, and today it's 3.0, and tomorrow it's 2.8, I will just start them on some prophylactic, like not KCL, like Fosnac or Nutrafos, because if their kidneys work, it's hard to make them overdo with phosphorus. It's the risk and benefit ratio probably is in the favor of just supplementing them. So the role of the primary care provider, I mean, it's critical. Those of you in the field seeing patients in the ground, like, you're the ones who know them best, and you know the family best, and you know what's normal for them and not. So primary care providers play a critical role in the early identification. And we know early identification does translate to better prognosis, because you can really start to hopefully get people some treatment. The other roles in childhood and adolescence, crucial periods for that counseling, the anticipatory guidance on what's normal growth and development, setting the stage for, like, it really isn't normal to be the same weight from when you're 12 to when you're 18 to when you're 25, because of all of the tissues that need to be accrued. And then the early, referrals for treatment and early treatment of any medical complications that may occur. So, what's involved with the initial medical evaluation? I mean, there's many parts of it, but one of the big ones being not only deciding whether you feel like you can call someone with an eating disorder and or refer, but also rule out any other organic diseases that may be contributing. So also looking for signs or symptoms of pituitary or hypothalamic suppression, which may be due to malnutrition, and I have occasionally seen due to something else that was masquerading as malnutrition or eating disorders. So for girls, a menstrual history is very important. So both finding out when their last period was, the period before that, and what their regularity was before that, knowing that within the first 2 years after menarche, it is incredibly normal to have anovulatory cycles and therefore irregular menses. But if there's somebody who has had regular menses before that, if they're missing periods, that's a reason to be concerned. For boys, we don't have the period to rely on, but there are good signs to show whether their hypothalamic pituitary gonadal axis is functioning. So libido being something that you can ask about, generalized energy level, morning erections or nocturnal emissions. You would be surprised, but adolescent guys, because they don't get asked very often, they're often very open about it if you're not non-judgmental and explain why you're asking. Sometimes they're very relieved to be able to talk about it. So those can be good signs of hypothalamic pituitary axis malfunction. Looking for physical signs of purging. So I'm just jumping ahead. I kind of glanced at the Q&A. Somebody had asked about Barrett esophagus. A relatively late sign, right? The dysplasia. But you can see certainly other signs of purging before that happens. Enamel erosions, so that, even if they don't have massive dental caries, those like hyper white patches, right, on their dentition, the yellowing, right, of the loss of the enamel and the exposure of the dentin. If they use their hands to induce purging, you can see what's called the Russell sign. Hyperpigmentation or scarring on the knuckles from kind of rubbing against the teeth. But if they use something else to induce purging, and some people don't even need to induce it, they can just kind of bring it up on their own, you may not see that. Enlarged parotid glands. It's helpful if you know what somebody's face looks like at baseline, but you can kind of feel here, or submandibular enlarging of the glands. And then if you feel, it feels like a discrete hard or like kind of spongy mass over the parotids or the submandibular glands. Are they having other serious medical complications? So looking at the vital signs, it seems kind of silly, but I actually had somebody referred a little while ago, and we didn't have any vital signs to compare to because the office that they were going to didn't regularly check them. So it is helpful to just check for even for just like a healthy kid who's coming in for a sprain or whatever, because you never know when that's going to be useful. If you happen to check electrolyte abnormalities like we talked about, signs of GI bleeding, upper GI bleeds being most common, especially for purging. We've also seen some young people have like kind of spontaneous pneumothorax or pneumomediastinum, which can just be, it can be from purging, but it can just be from malnutrition. So strange signs of pain, chest pain, that kind of thing. And then the last question being like, as always, like, can this patient stay in the outpatient world or do they need more monitoring? And again, if ever any questions or you're not sure if somebody should be admitted or not, just call and run it by us. We're used to it and we're happy to talk it through with you. From a physical exam standpoint, so like brand new patient coming to see me in clinic for a new eating disorder eval, kind of what do we generally do? First off, I have them get a dry weight. So in their underwear and gown only after voiding. It's really to avoid the arguing about like, oh, well, I had a giant bottle of water before and that's why I lost weight this time. And, so you just like have a real sense of like, this is what this person's dry weight is without their giant combat boots on, etc. Because the goal would be, if they're malnourished, for them to gain steadily, whether they're inpatient or outpatient. Getting a height so that you can calculate the BMI, also to compare it to previous, right? Have they fallen off? Have they lost some growth velocity? Vital signs like we talked about, and we had talked about how to do the orthostatics. And then, complete physical exam, including a sexual maturity rating, a Tanner stage, of both breasts, if they're female-bodied, as well as genitals. Because if there's differences in Tanner staging, if they're amenorrheic but they're Tanner stage 2, you know what I mean? Like maybe that's okay. So it also just helps put it all together. As a part of that, I kind of tell them I'm going to do an all-over skin exam because you can see lanugo or signs of cutting or stuff like that may be hidden under their clothes. I usually get an electrocardiogram when I first meet everybody for a new eating disorder evaluation to assess the heart rate, to look at the QT. Sometimes for young people who are questioning whether their bradycardia is due to an athletic heart or not, looking at the voltages can be very helpful with them, right? Because if you have somebody who's like a super athlete and that's why, they have a lower than normal resting heart rate, you would expect those voltages to be normal, if not larger, from the increased ventricular mass versus somebody who has bradycardia due to malnutrition. Like they have teeny tiny little voltages because there's just not enough cardiac mass to conduct. In terms of labs, generally speaking, these are the labs that I would get for an initial eval to rule out other causes of, whatever the presentation is, and also to see if there's evidence of systemic effects from the malnutrition. So I get a UA. I don't get a clean catch. It's just a regular dirty catch, mostly to look at the specific gravity to help you interpret those vital signs. If they're crazy orthostatic and their spec gravity is like off the charts concentrated, like you maybe take that with a grain of salt, versus like they're gaining tons and tons of weight, but their spec grav is undetectably dilute. Maybe some of that is fluid. The pH can be helpful to tell you whether there's purging. It's not a perfect slam dunk measure, but it can be suggestive of purging if the pH is high. A CBC and ESR or COP, right, to rule out signs of inflammation because you should not have an elevated ESR or CRP if you are malnourished. The CBC, you can have basically any cell line down because you don't have enough substrate to make those cell lines. So they can have anemia, it's generally mild. Thrombocytopenia is a relatively late sign but can happen. Leukopenia is also very common, and that should improve pretty rapidly with better nutrition. If we were to put these people in a scanner, you would see that their bone marrow actually has what's called gelatinous transformation. It's just not enough substrate and it turns into fat and doesn't really do anything. It is reversible, but it's kind of scary to think about. We talked about the electrolytes, liver and renal function tests. These can be wildly abnormal just from malnutrition. You basically can have hepatic autophagy when you're malnourished enough that your body will break down its own liver to try to survive. So even in cases like that, the LFTs may get up into the hundreds, usually not a whole lot higher than 100, maybe peaking at 200. The worst I ever saw was 6,000 in somebody who was admitted from like florid refeeding. But it's pretty common to have mild elevations in AST, ALT, as well as kind of mildly decreased EGFR or it's hard to interpret creatinine because often their skeletal muscle mass is so impacted that their creatinine is actually a little bit low. But when we look at, there was a paper from a couple of years ago looking at inpatients and their renal function, many of them had like a transient AKI from malnutrition. Hormonal studies, everybody always thinks it's their thyroid, and it very rarely ever is, but we check. So getting a screening TSH and a T4, they can often have a sick euthyroid picture. If the TSH is high, like 9, I might send antibodies just to rule out like Hashimoto's. But it's often just a like mild transient elevation because of sick euthyroid, and then you can repeat it in a couple of weeks and it usually resolves. The T3 is often very revealing because it's a better marker of overall nutritional status and it's often low. And it's kind of like, well, that's why you feel terrible if you have no T3. And then in females with amenorrhea, we'll check a pregnancy test, obviously, estradiol, LH-FSH, and a prolactin. And then in males, we're trying to be more standardized about getting testosterone levels because I think it's also just really helpful from an educational standpoint for families to know, like, again, you might be going to the gym a whole lot and you might be able to keep up with your schoolwork, but look, your body's running on fumes, your testosterone is 4. And then you want the LH and FSH for both of those things to be able to interpret the level, right? That it's not primary ovarian or testicular insufficiency. And then I get a 25-OH vitamin D on everybody. It turns out we're all low. And we're targeting a level of at least 30, so many people can benefit from supplementation. And this can be very helpful from a bone health perspective. That's the other thing that I haven't touched on yet, but like it's less about the period and the testosterone itself that we care about, and more about how that impacts your skeletal system. That you just only have this much time in adolescence and early young adulthood to accrue bone density. And once that window closes, it's very hard to make up. And there haven't been any really great convincing studies on exogenous hormones or bisphosphonates or really any other medication that makes a huge difference on bone health. It's really nutrition and getting the gonads to a place where they can make appropriate hormones themselves that really seems to make a difference. The last thing that I will say is I may consider a DEXA, so a bone mineral density scan, on people who've been amenorrheic or have had low testosterone for a year, because it can help guide you on what is safe to do from an activity level. It probably doesn't change your management a whole lot beyond that, but if you have somebody who's very interested in sports that are high risk, for particularly a vertebral compression fracture like gymnastics, diving, horseback riding, that can really change your management. Skiing, if they have low bone mineral density, you may steer them away from those types of activities and towards other types of things while they're recovering. So outpatient management, briefly, I acknowledge that this is very, very hard to do in a primary care setting. And I also acknowledge that it's often what is asked of primary care providers because there just aren't enough providers. So in general, the goal is to gain 1 to 2 pounds per week. And my kind of takeaway is if they're not gaining, they're not eating enough. So for whatever it is that they're doing, it's really about the weight, and that will tell you. So if they're not gaining, it's maybe a difference of they're doing too much activity, or they're not eating quite as much as they think they are. And so just add. I've actually very rarely had to have a talk with somebody that they're gaining too much. I won't say never, but like maybe once or twice in the last 15 years. Because more often than not, they kind of underestimate what they're eating and overestimate how much energy they're expending. I mean, underestimate how much they're expending. The treatment goal weight, um, it's a bit controversial. It's a little tricky, but in general, we try to get them back to their pre-morbid growth curve. If none is available, then estimating a treatment goal weight that corresponds to the 50th percentile BMI, therefore taking into account their height, is a fine estimate. But in general, even with these estimates, you really need to get them to a point where their vital signs are stable and they're having regular menses. Wherever that is, like can't fight City Hall, it's just kind of where they're meant to be for that time. For patients with atypical anorexia or patients who started off higher weight, even overweight or obese, and lost weight abnormally, you may not need to get them all the way back to where they were. Those studies have shown pretty consistently that even people with atypical anorexia have to gain some weight to regain the period if they've lost it. You would really just want to watch them closely and get them to wherever it is that all these things are functioning normally, and then have them maintain along there and see what happens. Checking hormones can be helpful to make sure that they're not overdoing it. There was a case of somebody who had atypical anorexia who lost weight abnormally, lost their period, and then gained and then developed PCOS. So, I think those are tricky, and so getting the data can be helpful. But in general, like we will use 50th percentile BMI unless there's a great compelling argument that somebody needs to be above or below based on their historical growth. While this is happening, you're not keeping them completely inactive. You will start increasing their weight-bearing activity as they gain weight because it's important from a bone health perspective and a mental health perspective, with appropriate increase in their intake for every increase in activity. So I usually say like the equivalent of a snack for every, significant increase in activity. So they return to PE, they return to soccer, you're going to add at least 1 or 2 snacks in there so that they don't lose weight as a result of increasing their energy expenditure. And in general, we recommend parents be in charge of the nutrition. Like Dr. Dada said, eating disorders are generally egocentric. So they don't like change. They don't see that it's a problem. It's all our problem. And so it's very, very hard for a young person who is actively having an eating disorder to decide to make change and enact it in a way that is lasting without help. So generally we say just parents take over, as if the kid had a horrible pneumonia and needed to be given their antibiotics. Like you don't just like say like, hey, good luck with that, hope you take it on time. Like the parents would give it to them and make sure that it happens. The same with eating disorders, except that the food is the medicine. And this is why therapy is so important, because the goal is for the family and the patient to work with a therapist on gradually increasing independence age appropriately around food, while they're in the process of becoming weight restored. So to wrap up our case, 3 years later, SH had 5 inpatient admissions. She did residential, I believe, and then stepped down to kind of a day treatment program and then outpatient therapy. She had family and individual therapy with mom. We actually got her wraparound services. So there was a social worker who would go to the home and eat with them, which is hard to get, but was very helpful for us to see what was happening in the dynamic between them, because it turned out that mom had her own mental health challenges that made it hard for her to feed SH by herself. And she achieved weight restoration and had complete resolution of her cognitive symptoms. She was an amazing kid. She went from being 12 to being like, 18 and bopping around San Francisco all by herself, like doing her own internship. So she did awesome. And that is, the goal and truly what happens for the majority of people. They do get better. It just takes time. And so it takes patience, but they do get better. Otherwise, you honestly couldn't do this. So here's some references, and then I think I took out that slide, but to get a hold of us, you can always call the clinic. You can call the Stanford page operator. There's always two of us on call at any given time, somebody just for consult questions, somebody for admissions, and we have 3 nurse practitioners and 3 fellows, so there's always somebody around to answer questions, and we're always welcoming them. We always want to hear from you guys. So with that, I think we're happy to answer questions. I can kind of read them out, and then Dr. Dada and I can try to help them. So, okay, so the first one being, is there a link in prevalence to certain activities such as gymnastics, ballet, etc., or is it more of a correlation, not a causation? Dr. Dada.
Again, so I think correlation, not causation. Yes, correct. I saw a question further down about masking requirements and whether or not that has been a reason that restriction has increased as an excuse to restrict. So to kind of link both of those together with the exercise piece, there was a recent paper published by my team that was looking at, in the context of the pandemic, whether or not eating disorder behaviors look worse for kids diagnosed with anorexia during the pandemic compared to a cohort of kids that were diagnosed before. And what we actually found was that the weights were lower and exercise behaviors were more compulsive and worse. So we see that. So I feel like that kind of touches on both these questions. It looks like it's correlated. I don't think that if you're doing ballet, you're going to get an eating disorder, or you're more likely to get an eating disorder. But certainly there are things that ballet and gymnastics promote, like needing to, like a preference for a certain size, or like wanting to be smaller in order to do flips. Same with cheerleading, things like that, that could maybe put some of those like bad ideas into somebody's head, but I don't think it would cause an eating disorder.
Yeah, I agree with that. That while the literature will support that some of these like more aesthetically based activities have a higher risk, it's not necessarily a causative. And I would flip it also to what we're seeing in boys is that boys can absolutely be diagnosed with anorexia and have body image concerns, but what they may express is a little bit different than what girls do. So they may express more of a desire for muscularity and less of a like wanting to be a certain number of weight. And so there is like this emphasis on physicality, but it looks a little bit different than we might traditionally think. There was also I'm just thinking anecdotally, like the trauma before the pandemic, because trauma can be associated, was I had a rash of young people a couple of years ago who were being trafficked when they were moving from like South and Central American countries and were being trafficked across the border. And it seemed like that was a trauma associated with kind of the onset of their eating disorders. So it can be many things. The next question would be, how do you involve the RD in care? Oh, they're so important. There isn't really great evidence, I will say, about like what is the best way to involve a dietitian. And Dr. Dada is an expert in this and I am not, but in family-based treatment, actually like it's really the family and the therapist that maybe the dietitian, while a great adjunct, isn't necessarily necessary if you can't access it, but I think they can be so helpful. In our clinic, they always see the patient in the initial evaluation with us. So first they'll see Dr. Dada and she sets the stage. Then they'll see me and I'll be like, these are the things you need to do from a lab perspective. And then they see the RD who gives them a nutrition prescription of like, what do the 3 meals and 2 snacks look like? We don't give meal plans. We really try to empower the families to problem solve in their kind of natural environment as much as possible. But she'll kind of give them ideas based on what they would normally eat and how to optimize the foods that they normally eat as a family. And then they can see her as much as or as little as they like. In our clinic, they're there with us most days of the week, but many patients and families choose not to see them every time, just if they have a question, or if there's something specific that we wanted them to follow up with a dietitian for. And so I don't think it's something that like should hold up your treatment of them, but can be a nice adjunct. And there certainly are private dietitians who are well versed in eating disorders. The one who's most famous in the Bay Area is Wendy Sterling, who has published a number of books that I like to give to families. No Way, the Plate by Plate model, all of these are really helpful, like adjunctive resources.
And I will just add to that, that one of the things that, so in the context of FBT, what we do try to tell parents is that you are the expert in your child. Like you have fed your kid their whole life and everything's been fine until this eating disorder came in and made you question everything. And don't let that throw you. You're still the expert in your child. You still know what to do. And so working to empower parents is really sort of the crux of that first phase of treatment when they're taking over renourishing their kid and helping parents feel empowered, like they can make this choice. Like, so what are you going to give them, a plate of carrots, or are you going to give them something that's a little bit more dense? They know what to do generally, and so it's working in that context. But outside of the context of FBT, I feel like I've worked with several nutritionists, dietitians, and it's been fantastic, and they have really, really valuable input. And sometimes the kid is better hearing it from them than they are from the therapist too. I've found it's nice.
Yeah. And there's a number of resources that I think I see private dietitians use more often than ours, like Recovery Record, that can be helpful from a, like an accountability perspective. So the kid, I think we can all debate how helpful this is, but in somebody who's like recovery motivated, they can log what they're eating and send that log to the dietitian, and the dietitian can give them feedback. Like there's tools out there that some private dietitians like to use. The next question, regarding anorexia nervosa, does the requirement mean that people who are already overweight cannot be diagnosed with AN?
Yeah, that would be atypical
Yeah.
anorexia.
So that would be that would be a case where maybe that person would be diagnosed with what's called atypical anorexia nervosa. So they've lost weight through an abnormal means. They have body image disturbance and a fear of gaining weight. It's just that they started higher, and so they lost and they ended up normal. Um, you, I think we could argue about whether physiologically that's really different. The studies out there on atypical anorexia show that actually it's more about your cadence of weight loss, the amount of weight you've lost, at how severely you present physically, and less about your absolute weight number. So I tend to think of them as just like one category. It doesn't really matter to me where you started, you're having the same physical effects. Where it matters is like that targeting that treatment goal weight, because a lot of them understandably have a lot of fear about getting back to where they were. It's using those other objective measures to figure out if they're stable or not.
Absolutely agree.
Awesome. Oh, okay. This one's for you, Dr. Dada. The single most common barrier I face in getting treatment for my patients is getting buy-in from parents. Do you have any strategies for getting parents to buy into the diagnosis and move towards getting treatment?
Right. So this one's tricky because by the time they come to me, the parents are like, "Oh my gosh, like we are so worried. We want to help immediately." And so the buy-in is kind of there. Um, Strategies to get parents to buy into the diagnosis. I think just some general psychoeducation about the dangers of eating disorders in adolescents and the harm that it can do. Like I feel like the thing that I have heard on our hospital unit is parents are like, "Oh, their heart rate's low, but that's good, right? They're an athlete, right? Like isn't that what we're all aspiring for?" So giving some education, like what Dr. Vo highlighted about how much an adolescent needs compared to like what their kid might be eating, and the impact that it can have on their cognitive development, their physical health, their mental health, and ways in which maybe that they see their kid as different. The eating disorder has hijacked them a little bit. We talk a lot about the eating disorder as like a separate entity from the kid. And I even have kids draw like a Venn diagram, like this is you, this is the eating disorder. Usually in the beginning of treatment, they're like very overlapped. And then at the end, they should be separate, maybe still there, but separate and not covering any part of the healthy side of them. And so think using like tools like that to point out to the parent or illustrate just how severe this illness is, and that their kid is struggling and suffering, might be a good way to get some buy-in. We also have an analogy that we use in FBT to cancer. So like we don't know why eating disorders start or how they develop, but they're serious life-threatening illnesses just like cancer is, and they need aggressive early intervention. And that sometimes gets a hook as well. So hopefully that's a little bit helpful.
No, it really was. And I think if you're in a primary care setting and you're seeing somebody for a checkup, and they're not yet ready to like really think about the diagnosis, I think focusing on the physical effects can be really helpful. Pulling up the growth chart and showing like, hey, this kid has always grown like perfectly beautifully along the 50th, and here we are at the 5th. Like that's not normal. And talking about the bone health effects, actually, that one seems to land really well, not for kids, but for families. Kids are like, whatever, I don't care. But families really seem to really understand that this is the only opportunity you have. You don't want to have a pathologic fracture at 30 from picking up your toddler. Um, so that can be really helpful. The other thing that I think kind of the most common disagreement maybe families have with us is around the bradycardia. So there are some really great, well-published norms in the Harriet Lane Handbook and Circulation by the like AHA of like percentiles of normal heart rate percentiles for adolescents. And so yes, like the parent may come in and be like, my heart rate is always 42, and it's like, absolutely. Starting around age 35, we each lose 1 to 4 beats per minute every year as our bodies slowly die. But for an adolescent, that's actually really abnormal. So teasing out the differences between a growing body and an adult body can also be helpful for families. I myself like actually don't necessarily label people if they're not like ready to hear it, because they'll just focus on that instead of focusing on the task at hand. So what I will talk about is growth and organs and stuff like that, because that I think most parents can get on board with. In a very, very extreme case of you have somebody who has medical comorbidities from their eating disorder and the family just will not agree, like, I think those are cases where thinking about how CPS can be not punitive but helpful in encouraging them to get appropriate treatment, it's I think it's valid to consider. So, we had a case over the summer of a young person who, an international student at a Bay Area boarding school, parents were living in another country, and the boarding school like dropped this kid off at a brand new pediatrician's office, and we're like, we're worried about her, and she had a heart rate of 32. So she needed to be admitted, but the family was like not at all on board with this. That was a case where we had to think about like, this child living in the US is entitled to the same protections any child would be to get the same medical care. So is this a case where we would have to kind of mandate treatment through CPS? It's the kind of thing I would think about. Doesn't feel great. Let's just be honest. So in terms of the leptin question. Okay, so thank you. The webinar has been interesting and eye-opening. And then I mentioned how leptin in adolescents can affect the development of an eating disorder, and to talk about that. So it's really interesting. There is a group in Italy that's doing a lot of this, these like kind of micro imaging studies. And their hypothesis is that leptin plays a role specifically in later stages of puberty, because if you're restricting in earlier stages, in childhood or earlier stages of puberty, your leptin is upregulated all the time. You've got this crazy high leptin that's like bouncing around your brain all the time. And while like your brain can withstand that for short periods of time, if it's been happening for longer periods of time over the course of months or years, that upregulation then subsequently becomes even more dysregulated and actually causes damage in the brain that makes it so that you can't respond appropriately to leptin and ghrelin. And so you really can't rely on your hunger signals, and the reward pathways of eating get dysregulated. So that's the theory of why maybe there is something specific to the developing brain, and why even though the person may be physiologically hungry, they can't respond appropriately to it. But those studies are ongoing, and it's like just so interesting. I don't know if you have more on that, Dr. Dada.
I don't. I find it interesting to hear your answer too.
It's crazy, right?
Yeah.
Crazy.
Yeah.
Mm. Okay, are there BMI percentiles for and for under 18, since those cutoffs are for adults?
So this was on my slide, I think, and it was just pulled directly from the DSM-5. And you're right, BMI is not a great metric for adolescents. What we use, and I feel like from a psych perspective, we leave the goal weight like stuff to the doctors, the MDs, and then we go off of that and tracking their weight. But we don't use BMI, we use kind of expected body weight, which is using CDC norms of weight, height, percentiles. And that is kind of more of our metric for kids. Is that kind of what you'd say too, Dr. Vo?
Yeah, we don't really use hard BMI cutoffs for kids to determine whether they meet criteria for anorexia versus like atypical anorexia. It's more about their percent of their treatment goal weight or their expected normal weight, whether that's median BMI, so BMI at the 50th, or higher or lower. This DSM-5, if you're ever interested in some light reading, has some like cases that extrapolate like the hard adult BMI numbers and presents like how you would extrapolate that for kids. And this can be very valuable from a research perspective, but I think from a clinical perspective, like you're looking at this growth chart. Are they underweight for where they were? Like that's what really matters. And where knowing the exact number can be helpful is determining the need for admission. So we will admit people who are just underweight if there's 75% of expected body weight, so weight corresponding to a BMI at the 50th percentile. That can be a reason for admission because we know being under that increases your risk for refeeding syndrome. And you don't want that to happen, just them chilling at home. So that's why we might admit for low weight. But there's no like kind of hard and fast cutoff for like qualifying for one diagnosis or another. This next question is, are we considering seeing Barrett's esophagus as one of the telltale signs of diagnosing bulimia? I kind of alluded to this because I had seen this, and it's a really good question. But because Barrett's esophagus, which is dysplasia of the lower esophagus from like chronic exposure to acid, because it's a relatively late sign, if we remember from medical school, it generally affects like middle-aged type people, even people with bulimia who have chronic exposure to that stomach acid probably will not develop this until later in life, like young adulthood. So we don't usually see this in teens. I don't think I actually ever have. If you were to scope them, because many of them end up getting scoped for one reason or another, they might see they see some like redness and irritation, but I've never seen it like be biopsied and called dysplasia before. But certainly a risk and worth talking about with people who purge, because that is one, and please correct me if I'm wrong, Dr. Dada, but that is one you have in the like otherwise very egosyntonic nature of an eating disorder. Like people who purge don't like purging. Doesn't feel great. And so often they do want to interrupt that behavior.
Yes, and there are some that get some secretive joy out of it. That's later when they've been sick for a really long time and have a bunch of other stuff going on.
Yeah. The next question, the percentage of ARFID that goes on to anorexia or another eating disorder.
Such a good question. I actually saw this question and I did a quick Google search of any articles that came out recently, and I didn't find. So this has been something that's been thought, and a lot of parents worry about this in my experience, that if their kid has especially low appetite ARFID, people consider that like early anorexia, or if untreated properly, will go on to become anorexia. There's no evidence actually supporting that. I've had parents with that concern. I've had kids with the concern that ARFID will become like binge eating disorder, actually. So to address or any other eating disorder diagnosis, part of that question. But there is no empirical support to say that that happens. And I think that's largely because ARFID is so new. We don't have good longitudinal data following kids from early diagnosis, treatment, and then into adolescence and adulthood. So, but a good question, and hopefully research efforts are underway.
Yeah. And these are kids that you'll likely follow because it does take, on average, a year and a half for kind of resolution of the initial symptoms and improvement of the psychological symptoms in generally all of the eating disorders. So you'll follow them over time and as they mature. And it is certainly possible that somebody who's younger, diagnosed with ARFID, then has the cognitive capacity and the language capacity to express body image stuff that was happening before, but they didn't really recognize. So, kind of following them over time can be really helpful. This next question is a good one. Can you discuss PANS and PANDAS, restrictive eating symptoms, and how to rule out?
Right. So this is a great one, and not really my area of expertise, but I'm very interested in learning more about the overlap. A big commonality from what I'm remembering is OCD features. So really somebody, I think, asks a question later on about like if a green pea has a scratch on it, like that level of detail focus, and similar OCD type flavors that you see in kids with PANS or PANDAS and ARFID. I do know that currently our PANS clinic is administering a bunch of ARFID measures to see how much they overlap. And I do think that there is an initial paper under review that talks about the overlap between those symptoms, and should it get published, I will circulate it. It's a great question. I think that they're highly comorbid, and I don't know that one leads to the other, though. I don't think we know that yet.
No. I think historical clues for me that this may like not be PANS or PANDAS is really drilling down on, did they have any of these things kind of before the acute illness? Because with PANS or PANDAS, you expect them to have had an acute illness and then development of all the symptoms. So it's a pretty common of all the things worry that families have of like, is this PANS or PANDAS? But then you get more history and it's like the kind of kid that was very anxious just from toddlerhood on, which doesn't really fit with PANS or PANDAS. Or they've had a lot of difficulties in other areas even before the acute illness, so that can be really helpful. And for me, I try to be thoughtful about the medications for PANS and PANDAS because I think they're not without risk, and I would really want expert guidance on whether those types of things, like even chronic antibiotics, even, up to like IVIG. I have a patient who gets monthly infusions of IVIG for his PANS. Like, it's expensive, it's not without risk, so really thinking through whether that's kind of the best treatment and if it fits with the picture. Do we have specific recommendations for ARFID? Yes, we do. Dr. Jada.
If you have a child between 6 to 12 years old, there's a treatment study they would be eligible for. So there are no like standard of care treatments yet for ARFID, but there are lots of different treatments underway. So there's like CBT for ARFID that's being adapted by the group in Harvard. There's interoceptive exposure kind of therapy by the group at Duke. And we at Stanford are looking at psychosocial motivational therapy compared to FBT for ARFID. So lots of different things to see what works. ARFID is so heterogeneous in the 3 different subtypes we described that it might be that one therapy does not fit all, and kids might need to have a treatment tailored based on what they're presenting with. But I think that getting assessed, getting treatment and support, lots of times for kids with ARFID, parents have been doing a lot of accommodating to reduce conflict around meals for many, many years. And so disrupting those behaviors with support and ideas about how to start to really slowly introduce change. So if they only eat the specific brand of chicken nuggets, try and getting them slowly to branch out and like with gradual exposures, like something similar but a little bit different, and something similar and a little different, and introducing different foods to increase their overall eating repertoire. I think things like that, but helping support parents and making some of those changes through therapy.
Mm-hmm. And occupational therapy can be a very helpful adjunct as well if you have access to it. We have an incredible occupational therapy department here at Stanford. They see patients outpatient, and like it's pretty rare to have such skilled people that are willing to see adolescents and even young adults, because often feeding clinics that I've seen in the past have kind of cut off at a very young age. So if you have access to that, it can be very, very helpful. Um, Medications can be helpful as well, depending on what the subtype is. So for kids who have comorbid OCD or generalized anxiety and SSRI, like Zoloft, can be really helpful. If there's an element of like inattention, making sure any comorbid ADHD is addressed can also really be helpful. These are cases where, like ARFID, not anorexia, if there's a lot of anxiety around meals, potentially like medication in the initial phases of treatment could be something you would consider, but we really try not to medicate the eating disorder because it's upset about eating in like anorexia or bulimia, because it actually doesn't really help unless they have comorbid depression and anxiety that predates the eating disorder and is like separate from it. More often than not, those things don't help. But in ARFID, Zoloft, a little atypical antipsychotic, those things can be really helpful. This is a very common question, the next one. You mentioned sometimes adolescents with anorexia do not want help. And how can treatment be successful as a person's not motivated to change?
In the context of FBT, which is what we most commonly do in our outpatient clinic, kids are not in charge of their eating for phase 1. I think there's a question later down about like developmental appropriateness for that. The way that we kind of pitch it is that like right now the eating disorder is in the driver's seat and making the decisions. We know that's not you. So we're going to have parents take over the feeding and plating and all of those decisions. Kind of saying that like right now the eating disorder makes it so difficult for you to do all the pick what you need to eat, what's a healthy thing to eat, how much to eat. We're going to eliminate all that so that you can focus on the one most important thing, which is to actually take that bite and eat the food. And parents are going to worry about everything else, and providing support that way. So they don't really have to want to be in treatment. In fact, I'm sure that most of my kids in phase 1 really don't like me and are not happy about seeing me. But I promise as they move through phase 1 and the weight gets better and cognitively they're more there and they start to emerge from behind that eating disorder that's covering them, they're more into it. And we start to talk about different things like developmental issues, and they start to take over control of their eating. So it's not like parents are in control of eating forever. They actually want that control back. And when they're able to do it gradually and in a healthy way, it's actually really rewarding for everyone involved. Parents are sick of doing it. Kids want it back. And as the provider, you're like, yes, we're getting the actual kid back. So to answer the question, they don't have to really want to be super excited for treatment initially in FBT.
And that's actually part of it, like the eating disorder is protective of itself and rejecting of anybody who challenges it. So I would agree that like often they're like, well, I don't want to see that Dr. Vo. Which is okay, right? Because that means that like we're kind of appropriately challenging it. So if the motivation is as simple as I really don't want to see this doctor as often, like so be it. That's awesome motivation. So do what you've got to do, and then we don't have to spend your afternoon this way, which sounds a little bit callous, I know, and like is often the motivator. And so it's okay. And I often like you may find yourself like the eating disorder drawing you into a debate. Why do I have to gain this weight? Why do I have to eat this? Normal people don't do this, blah, blah, blah. And it is okay to kind of acknowledge like we may disagree about this, and it's okay. And I want you to know that I hear you, and no one wants you to suffer. And at the same time, like this is the medicine your body needs, and so we do need to move forward. And you'll be surprised at how often that like really contains the eating disorder. It stops arguing because it's like it hears the limits. So the more you can be clear and factual, actually the less it will freak out and get angry and stuff like that, because it will know where the boundaries are. It's when it doesn't see where the boundaries are that it really tries to test them, with families and parents too. So I also do say to them, like, I don't expect them to be really thrilled about this, and so therefore it is okay for you not to like convince them that this is what needs to happen. What matters is that you present them with the same amount of food and that they see that this is happening, because they, in many ways, probably will not agree. And that's okay. Eventually, it does get better.
Absolutely.
This probably is the last question we have time for, and it's a good one. Comments on the capacity to refuse treatments with known cognitive impairment for malnutrition.
Hmm. So I feel like there was another question about cognitive impairments related to malnutrition in terms of like, does it get better after recovery? Is there a scarring effect? And the cognitive impairments that I've seen clinically, and I think Dr. Bro can speak to this more medically, but a lot of rigidity, a lot of inflexibility. So difficulties with set shifting, difficulties with seeing the big picture, all these things can be treatment interfering, right? If they're not seeing kind of the light at the end of the tunnel, but are more fixed on the details and things like that. We know that that's issues in folks and adolescents with anorexia nervosa. Um, Again, in the context of treatments where parents are in the driver's seat, it's okay, because we can do the renourishment process and get their weight back up, get their cognition back online. Sometimes these kids, right, these kids can be like these straight A students that are super focused on school. And if they're in that anorexia fog, pointing that out and using that as maybe a motivator to want to get better, like, you know, how it's hard to make decisions, how it's hard to concentrate because you're hungry or because the anorexia is really kind of taking up so much space in your brain. Imagine all the things you could be doing if we weren't so worried about how many calories was in that bite of pasta or something like that. And so pulling on that side of them, the who they used to be before the eating disorder really kind of dug its claws in, can be helpful. And you do see a lot of that remit as their weight improves from a cognitive standpoint, as far as measures that look at set shifting and cognitive flexibility and things like that.
Acutely, like, you know, if we're talking about they're in the hospital and they're trying to refuse treatment, if they're under 18, like Dr. Dada said, they really actually, unfortunately, don't have that legal ability. It is up to the parents. If they're over 18, that's when you would do a capacity assessment, of whether they truly understand the risks and benefits, of refusing treatment. If they're on our inpatient unit and they're over 18 and they're deemed to have capacity, which actually most of them are deemed to have capacity except in very extreme cases, if they're refusing treatment, actually that we would discharge them against medical advice, because what we don't want to do is have the eating disorder feel like it's getting treatment when it actually isn't, that it feels safe, but it's actually not getting the treatment that it needs, which is the food. And so we want to make sure that we're being consistent and sending a message of like, this is not okay. In some very extreme cases of people over the age of 18 who have been deemed to not have capacity, we actually file for a 5150, a 5250, and a TCON, you know, depending on the amount of time. And then, which just says they can't leave the hospital, doesn't mean you can treat them. So then you have to file additional affidavit A and B if you want to like tube feed them, for example, or give them medications. Thankfully, the legal system is in the patient's favor for the most part of respecting autonomy. And in that way, as a provider, it can actually be very challenging to take care of someone who's very critically ill. In the pediatric world, thankfully, this is pretty rare. For young adults, though, it does happen, and that's kind of the process. I realize that we're out of time. I want to acknowledge Dr. Chikeni. I see your question. Please email me. Um, um, and but if you need anything, if you have any questions, please feel free to reach out to us, by calling the main Stanford Eating Disorders Program line, or emailing us, or reaching out through the CME folks. It was a pleasure to talk with all of you today, and thank you, Dr. Dada, for joining me. And I hope you join us again for the one we have in the spring, where I think we will talk more about ARFID.
Absolutely. Yeah, that will be great. Thanks for having us. This has been fantastic. These questions, I'm very sad we didn't get to all of them, because I've read all of them and they're really good questions.
Thanks all.